really my focus as Undersecretary was really the dollars and cents budget in just the administrative management of those programs. So I'm not going to get up here and say, oh, this is good or this is bad or this policy this. I'm just going to tell you based on my 35 years of experience what I think the impact is to the citizens of the state and ultimately to the 49 hospitals that I represent, the rural hospitals covered by the Preservation Act that are in 41 of the 64 parishes in Louisiana. So it is, across the board. And really, before I get to the next slide, I do want to say that, as everything, as I get older, I look at the world and everything is shades of gray. There's nothing that's black and white. And that absolutely applies to this bill. There are some things that are good in here for the rural hospitals. There are some things that potentially have an impact on the rural hospitals, but several years down the road. So, in fact, I've talked to probably a dozen reporters over the last 2 weeks, and first thing they say, well, how many rural hospitals are going to shut down? And I say 0, and that pretty much ends the interview, to be honest with you. And I'll get into why I'm answering 0 in these slides, but it is a case where people jump to things. I'm just going to tell you what I think and what I think the impact is. Okay, these are the topics. I'll go through them real quick. Eligibility changes, Medicaid eligibility, the finance and payment changes, and the new funding that's in the big beautiful bill, the new Rural Health Transformation Program. That's the $50 billion investment over the next 5 years into rural health across the country. Going the wrong way. Let's see here. Before I ever talk about expansion or talk about eligibility and numbers, I always like to talk to people or explain to people sort of the broad groups of eligibility or health insurance coverage in the state of Louisiana. In Louisiana, we have the Medicaid expansion program and the Medicaid legacy program. And you see those numbers right now. So right now in Louisiana, we have 1.6 million people enrolled in the Medicaid program. Okay? Doing the, just looking stuff up on the internet in Medicare right now, there's an estimate of about 900,000 people in the Medicare program. And then there's 1.8 million people that have private insurance. That leaves us about 300,000 people that are uninsured. Okay? So when you look at Medicaid expansion, Medicaid legacy, and uninsured, that represents 41.3% of the state either is in the Medicaid program or uninsured. So that is a huge percent of this. And you've got to always try to stress everybody that as you take people out of the Medicaid program, yes, some will go into private insurance, but the majority, a big bulk of them will also go into the uninsured program. And as Medicaid or Medicare pays less, then that puts pressure on the private insurance, the Medicaid providers, when they negotiate their rates with private insurance, to charge those guys more money. So it is all interrelated. We've got 4.6 million people. So you've always got to remember the providers are trying to balance their finances between those four groups, in essence, and how we finance that is always important. And with the large number of people in Medicaid and in the uninsured, that is the case. We've got more in those groups than we've got in private insurance. So it becomes very difficult to maintain operations, maintain the services across the state for everybody if there are material changes in the Medicaid or Medicare program. eligibility determination every 6 months. Right now, in Medicaid expansion, the adult program for 19 to 64-year-olds that that fit into the federal poverty level under 138% of FPL. Right now, we redetermine eligibility every 12 months. Now we're going to every 6 months. So every time you go through eligibility determination, there is going to be a certain percent of the population that falls off. Now, one side will say, well, that means that they shouldn't have been in the program and they should go get private insurance from their employer. But we also know that there will be a certain percent of them that fall out of the Medicaid bucket on the previous slide down into the uninsured bucket. Okay, that starts December 31st, 2026. And in fact, I think in the state legislature, they passed a law to do that. I think Senator Cloud was passing that this last legislative session to speed up how often we do eligibility determination on that eligibility group. Let's see here. And remember when I said, so on the previous slide, Medicaid legacy and Medicaid expansion is 1.6 million. That first address confirmation applies to all 1.6 million. The redetermination every 6 months only applies to the Medicaid expansion line, so that only applies to those 500,000 individuals. So that's why each of these changes affect the different populations a little bit differently. The last one on here is the community engagement requirements in sections 7, 11, 19. That is what has been called work requirements. It applies to adults in the Medicaid expansion population that are 19 to 64, and they need to work, attend school, job training, and do 80 hours per month, and that's going to be effective for January 1st, 2027. There are some exemptions on there. If you're taking care of children under 14, taking care of aged adult, elderly parents, those types of things would also meet that requirement. So, one side will say, well, that's a good thing. We're encouraging the people on the Medicaid program, these adults that are on the program, engaging in the community activities, everything else. Other people say, oh, this just creates more administrative burden and will reduce the number of people that are on the rolls. The one example that I've read is state of Arkansas tried to implement, or did implement this on a population, and about 25% of the people came off the rolls. So I would guess right now, for the work requirements, right now we're probably talking about, out of that 500,000, maybe 50% of it, the people in that is going to be required to do that. And then you can just sort of do the math of potentially people that could come off the rolls and either go back into private insurance or go into the uninsured buckets. This slide right here is really talk about the Medicaid eligibility changes, those three things that I just talked about. Really, it's going to increase the administrative work on the state. The state's going to have to update its computer systems. They're going to have to become into compliance with these new federal requirements. And also, they may need additional eligibility workers, even though the state legislature probably will never give them additional eligibility workers. But as you have to touch that 1.6 million people more and more and more, you need more and more people in order to do that in an efficient and effective manner. So it is going to take some administrative investments in order to implement these. And also the clients. The clients are going to have to interface back into the department more frequently than they have historically. Some will say it's a good thing, some will say it's a bad thing. But every time they were required to verify their address or verify that they're working or that they're still eligible for the program, there's potential for them to say, oh, this is just too much trouble. I'll just get out of the program. No big deal. I'll go back to the uninsured and that. So it is a case where as you increase those administrative burdens, based on what my experience and what I've seen, the examples across the country, you will start seeing a decrease in that of Medicaid enrollment, specifically in the Medicaid expansion line. You'll see less people in that role. So whether we go down to, from 500,000 to 400,000 to 300,000, that's up for debate, but you will see decreases in Medicaid enrollment based on those three requirements that are in the bill. And as you have more people uninsured, if you're uninsured, historically what has happened in Louisiana, when you get sick, you go present yourself at the ER because the hospitals have to triage you and have to treat you. And if you get sick, you present to the ER, which is the most expensive setting for the state to pay for, and you get your health care through that. Now, what will happen is the hospitals, if it is if it's a material cost for them to treat that patient, they will do everything in their power to get them re-enrolled into the Medicaid program. And there's another change that we'll be talking about, but it is a case where you will see increased uninsured care costs at the hospitals because of these changes. And that's simply related to, if you have more uninsured people, you'll have more uninsured costs that the hospitals are being presented with and have to treat. Going into the finance changes, I'll touch on these real quickly. The first one there is section 71120, and that's $35 copay for the expansion adults that are 100 to 138% of federal poverty limit. So that applies to that first line in the eligibility groups of expansion, those 500,000 individuals. If they're an adult in that 100 to 138, I really don't know how many of those 500,000 meet in that criteria yet. The department has not identified that yet. But if so, you will be required to do a copay, and it will be a copay really for specialist care. They've exempted primary care, behavioral health, FQHCs, and services at rural health clinics also. They are not required to do a copay at those things. But if you have to go see a specialist of any kind, say you got heart issues or whatever it is, it will be required a $35 copay. I'll be honest with you, when I was undersecretary under Governor Jindal, we implemented some copays, and the providers completely hate them with a passion. And the reason, and you just sort of think about it logically, what happens, let's say if you're a doctor and you're doing a knee replacement and you get $1,000 to do that, what the state will do is go in and reduce your rates from $1,000 down to $965 and tell you to go get the $35 out of the client, okay? If you're a client making $21,000 a year, it's going to be tough. I don't want to speak for anybody, but tough for them to come up with $35. So that's just human nature and what we've experienced, what I personally experienced seeing the impact of copays. And eventually the providers almost give up trying to collect the copay. And they just take the rate cut and continue to provide the services. So, but that's what a copay means to me. Since I represent providers now, that's what it does to them. The next one is also sort of an administrative burden on the hospitals, is they reduce retroactive eligibility from 90 to 30 days. So if you have an uninsured individual show up in your ER, let's say they have a broken arm. Of course, you fix the arm, you get them stabilized, send them home, follow-up treatments. You know at that point in time they're uninsured, so you have staff coming in saying, hey, we need to get you enrolled in Medicaid, we need this document, this document, this document, and they work with the clients over the time as they interact with them to get them eligibility for the program. Right now, federal law allows us to go back to 90 days from eligibility determination. This bill now changes it to 30 days. So that will increase the administrative burden on the hospitals and also increase the uncompensated care for the providers. Getting into provider taxes, that were a big change right here. Right now, it's section 71115. They freeze all current provider fees in place right now, and then they start ratcheting them down there in state fiscal year 28. The ones that are highlighted in red or in red font, that's when I think it will start affecting our provider taxes that we do in Louisiana. In state fiscal year 29, we currently have an MCO tax at 5.5%, so it will be affected in that year. And in 2030, Our hospital tax right now is about 4.6%, so it will be starting to be affected in 2030. As you can see, those are 4 or 5 years out, so it's hard for me to project too much, but it is a case where we do collect hundreds of millions of dollars through these programs that generate, you know, $1 billion or so in payments back out to the providers. So it does have potential to hurt the funding of the program in those out years, 29 through 32. The big impact in the out years is on supplemental payments, okay? And and I'll use hospitals, but this also applies to physician. When a patient goes and presents at a hospital, the hospital files a CMS 1500 form to the MCOs, it gets adjudicated, they get paid their rate for that, and that rate's about 78% of Medicare. Quarterly, we get supplemental pay, and those payments are funded with state general fund and federal money. We also, in Louisiana, we do supplemental payments for the hospitals and the physicians, and we take that difference between what the claims were, the 78% of Medicare, and we try to pay it up as close to possible as average commercial rate for the Medicaid program. And those supplemental payments are funded with provider taxes and IGTs and those different things that are funded. They're not funded with state general fund, they're funded with these other mechanisms that you've probably seen discussed at the national level. And so right now in the bill, it freezes all our supplemental payments at our current levels here that were contemplated in state fiscal year 26. So there is no cuts in state fiscal year 26 for hospitals, physicians, or anything like that. And they start ratcheting them down by 10% every year in 2029, okay? So when I said earlier there are no rural hospitals closing, that's because there's, 26 were absolutely funded exactly the way the legislature passed House Bill 1 this last legislative session. On here is a chart that shows, and this is nothing but Jeff's estimate based on the numbers I've gotten from the department and what I think will happen. But right now, you see in column B, for the 49 rural hospitals, we're budgeted to get 245.9. That's what we were budgeted to get in 26. Right now, I'm projecting that in 27, we'll get the exact same amount. In 28, we'll get the exact same amount. My personal opinion is that absolutely in 26, this is the rural hospitals are absolutely fully funded. There's no impact from eligibility. In 27, when there is no increase, they have to start eating the inflation, whether it's medical supply inflation, the cost it takes to hire docs or nurses and those types of things. And then in 28, that's when you'll start seeing the financing really start tightening up at the rural hospitals, because that's, there are no increases for inflation and they're having to continue to eat that. And then starting in 29 through 34, as the bill contemplates, there's a 10% reduction in those payments until 35, when I'm projecting they would get down to 100% of Medicare. Absolutely, this concerns me, but this is also 3-4 years out. Even 29, 30, I can't say any rural hospitals will shut down. We will have to start really managing those programs and see what we can do to prepare for this. And of course, during this time, we'll be working with our federal delegation and our state delegation trying to address these 10% reductions. And this reduction right here, as you see, is they would be taking about $2.9 billion out of the hospital program over the years. The physician program would be about $1 billion. So the 2.9, and then there's another small program that would be a couple $100 million. So you start getting up to about $4 billion coming out of the program over those 10 years. So it does cause some concern, but we've got to work with our legislators in order to figure out how to best address this going forward. And that's what we'll be doing over the next few years. The last thing, and this is the good, as I said at the beginning, we've got good news and bad news. Me being a retired state employee, I'm always pessimistic, so I start with the bad news. So that was the bad news. This is the good news. There is a new funding for rural providers. It's Section 71401, the Rural Health Transformation Program. Right now, I'm estimating at a minimum, Louisiana's going to get $100 million starting here in federal fiscal year 26, which starts October 1st through 2030, and we potentially could get up to $200 million. So sort of splitting that in the middle, about $150 million would be coming in. There is no state funds required, so I don't have to go talk to President Henry or the Speaker or the Governor about getting any state general funds. This is all 100% federal. LDH does have to apply for this money between now and December 31st, and they have to come up with a plan on how they want to spend this money, submit it to CMS, and get their approval for that. So for state fiscal year 27, those that are very technical, this will require JLCB to do a BA7 in order to give LDH authority to receive this money once it's approved by the federal government and to spend that money in accordance to the approved plan. And just to give you an idea, these are the types of things that are listed in the bill that this money can be used for. I don't know yet where the state's going to focus the resources. That ultimately is going to be up to Secretary Greenstein and Governor Landry. But those are the things that are, I just copied that out of the bill, and that's where we're at as far as what these funds can be used for. And that's the end of my presentation. Hopefully I'm on time and not too bad. Yes, sir.
The insurance premium tax credits that are set to expire this year federally, how much effect do you think that will have on Louisiana hospitals?
I just don't know. I haven't done a lot of research on that. As you can tell by my presentation, it's mostly focused on Medicaid. With that being in the health exchanges, I'm assuming there would be some impact, but just how much, I don't know. I would assume it would cause people to fall out of that insured bucket down into the uncompensated care, but I've yet to see or read any estimates of how many people we're talking about that would potentially fall into the uninsured bucket and force the hospitals to provide free care to them.
And just to jump in here, the floor is open for questions, so we've got about 15 minutes for questions, and if you think of repeating the question.
Yes, ma'am.
From Louisiana Radio Network. I know at the outset you said that you do not expect any rural hospitals to close. Obviously, a very different number from the 33 rural hospitals that Democrats are saying that are going to close. I was going to ask you, what the disparity in the numbers were, and I'm seeing this slide here. The 100, I think, is 100 to 200 million. And do you believe that this is the biggest reason why you believe that there will be no rural hospitals that will close as a result of the tax and spending bill that was just signed by the president? Is this the biggest driver? In other words,
this is a piece of it, and then just the timing of it. When we're talking, and he's asking about, why I'm saying there will not be any rural hospitals closing. It really comes down to timing. Once we're 3 to 4 years out, which that's what it's going to be before we start seeing potential funding reductions. This is potential funding increases during the same time. It's hard for me to predict. I'm not going to sit here and say what's going to happen 4 years from now because I just don't know. So that's really because most of these reductions that I've been talking about is in the out years, 3-4 years out, we are going to have additional $150 million over the next 5 years. So for the next 4 or 5 years, it's hard for me to say anything's materially changed that would cause a rural hospital to shut down. Once we get 4 or 5 years out, it's up for debate, but that's a long ways, and there will be a lot of things that change between now and then. So that's why I'm sort of saying, my answer is really that 3 to 5 years is what I'm talking about when I say that.
So the National Rural Hospital Association, their estimate is that this new program will only cover 43% of those projected losses. Can you talk about, if your projections are rosy, at least for the near future. How do you kind of reconcile those two things?
Well, I mean, obviously, if the annual reduction amount on this chart is $400 million a year. Now, that's every hospital in the state, not just the 49 rural hospitals. For rural hospitals, it's about $24 million a year. So it is a case where ultimately it comes down to where does the administration, the state administration, Governor Landry and Secretary Greenstein, want to invest that $150 million a year for the next 5 years. As far as, if you're doing it really comes down to, are we looking at between now and 2029? Are we looking between now and 2035 as far as reductions that are going to materially impact operations? I don't know where the national, the 33 hospitals that the Democrats put out. To be honest with you, I don't know where they got those numbers from, but that's their numbers. That's what it is. All I can say is based on what I know in my experience, it is as I said earlier, it's not black and white. It's the next 4 or 5 years we're probably fine. After that, we're going to need some help, and we're going to have to work with our legislators to see how we address that going forward.
To follow up on that, can you maybe touch on some of the funding measures or budget maneuvers we can do? I mean, we're already looking at a pretty slim budget for the near future here in the state.
Let me see. I'm sorry. Let me go back. No, it does. This change right here, where they say they have frozen all provider taxes, is concerning to me, because as I said earlier, the base payments to hospitals are funded with state general fund and federal money. The supplemental payments that everybody relies on right now is funded with provider taxes, governmental transfers from local public entities, and federal money. There's no state general fund in there. So once this is froze here and we're no longer able to increase that provider tax to increase growth in the hospital program, that will impact the state budget. And that is a concern of mine, is how do we continue to keep up with medical inflation in these payments when this financing tool has been, in essence, taken away from us, from the state. And it is a case where we're going to have to do some work and figure it out. I've been dealing with this since 1990. I've seen programs come and go. We always figure out something new in order to keep the services being provided out to the citizens of our state. I have a lot of faith in Secretary Greenstein. I worked with him under Governor Jindal, and we'll figure it out. But if you say, Jeff, what's the alternative to this? Today, I do not know.
How many of the rural hospitals are in really bad financial shape right now, pre all this coming down the pipe?
The question is, how many of the rules are in bad financial shape right now before this bill? There's just a few. There's 2 or 3 that we're actively working with in order to stabilize their finances, but it's not a huge number. And you've got to remember, in Louisiana, in the mid-90s, the legislature passed the Louisiana Rural Hospital Preservation Act. And in that act, it says the state has to maximize funding to the rural hospitals in accordance with federal law. And Louisiana has done a very good job supporting its rural hospitals. And we have not seen any closures of our rural hospitals like in Georgia, like what's being threatened in Mississippi, really because of the Preservation Act and the strong support from the legislature and the governor on driving that money to them to support their operations and keep them open. And in fact, the only rural hospital we've had closed since the 90s was South Cameron, and that was hurricane related, not finance related. So we started with 50, we're down to 49. So Louisiana should be applauded for its support of the rural hospitals and the support they've given them over the years, unlike what we see in some of our sister states. A rural it's in the Rural Hospital Preservation Act. I think it's less than 50 beds. There's some other criteria in there. It's in the community. And it was really what their status was in the mid-90s when the Preservation Act was implemented. I don't have those memorized off the top of my head, so that's the best I can do for right now. That a lot of them have rural. They are not classified as rural hospitals. Now, FMOL does operate one of our 49 rural hospitals, just like Auctioner operates, I think, 6 of them. So there has been some mergers or some, I don't want to say acquisitions, some agreements. Because you got to remember, of the 49 rural hospitals, a little over 30 of them are hospital service districts, which are operated by the police juries in the parish. So they're, in essence, parish-owned hospitals. So those, like the hospital in Walker, Louisiana, that the lake is open, that's not a rural hospital.
Got one more question.
Yes, sir.
This form that people are going to have to fill out every 6 months, it doesn't seem to be in the public record about what it looks like, so we can see how difficult and good it is to fill out.
For the form that requires address verification that's in the bill, yeah, until CMS, until the federal government puts in administrative rule what is required on that form, or what the states are required to collect every 6 months, or however often they want to do that, that's when we'll know what is required on the form, and then LDH would develop a form to in essence, capture the data that the feds are making us require. So until they go through the administrative rulemaking process, we're not going to be able to answer that or know that answer. Back.
You speak in hospitals. I want to ask about nursing homes.
Yes, sir.
Is there any need for concern for, say, the difference between urban nursing homes and rural nursing homes? Because that's what I've been told. These people want me to try to explain some of this. And it's very hard for me to explain that, because I know 8, 9 people that I visit a lot of times in nursing homes that are very concerned right now, especially now that we're in hurricanes.
Yeah. Well, specific for provider taxes, as I've got on there, nursing homes, there is a nursing home provider fee currently in place. That is not affected by this freeze or the funding for the nursing homes. So as far as funding-wise, I did not come across, of course I don't focus on nursing homes, but I didn't come across anything in the bill or anything in my readings that I think would impact the current operations of our nursing homes across the state. Of course, I'm sure they're coordinating with their local hospitals. I'm sure some of those rural hospitals, as that, and I would assume that relationship will continue for the next 4 or 5 years, and then we'll revisit depending on what needs to change at that point in time. But I can't tell you today, oh, this is going to affect nursing homes or not. I just have not seen anything. Yes, ma'am.
Right, just kind of talk about our viewers at home or anybody. Anybody that has concerns about the future of Medicaid, rural funding, things of that sort, what would you say to our viewers at home?
I would say that over the next 3 or 4 years, the funding for rural hospitals are not being affected by this bill. There are going to be some changes in the financing, some changes in eligibility requirements that may impact us in the future, and we'll have to address them as we get closer. But right now, my main message, as I said at the beginning, is immediately there's no impact. Now, as I outlined here, there may be some impact in the future, and we'll have to deal with that and figure out solutions and work with our federal delegation to address that. Yes, ma'am.
And this might be a question you can't answer. When you compare Louisiana to other southern states, is Louisiana in better shape because of expanded Medicaid from possible closures compared to other southern states?
Probably the southern state that I'm most familiar with is Mississippi, that has not yet done expansion. I do think that just having the numbers of people we have in expansion, the 500,000 people, if they were not in that program, the vast majority of them would be in the uninsured bucket. So that just puts more financial burden on the states or on the hospitals across the state, and how do you treat that population when they present in your ER and provide them care. So it is a case where I do think with expansion, and I was undersecretary under Governor Edwards when we did Medicaid expansion, and I'm very proud of the fact that we did that without getting one more state dollar or one more state bureaucrat to do it. And we put 500,000 people on the rolls and implemented the program. So I am proud of that, and I do think that did very much help stabilize the financing, at least in the hospital program, and I think in a lot of the other programs where you're just not dealing with so many uninsured people. And the other thing that expansion did, it really enabled the privatization of the former charity hospitals that I was also part of under Governor Jindal, have that come to fruition. And really, the elimination of, or the privatization of those charity hospitals, why they're so important to me is you got to remember when we went into those hospitals to start privatization, they had wait lists for 9 months to get a colonoscopy. You had unbelievable, when LSU ran out of money in the spring, they just stopped providing services until July started. So it was really, beholden, I really took it personal that we've got to fix this situation. The privatization of those charity hospitals was the first step, and then allowing Medicaid funding come in for those people that were previously uninsured and give them a funding source helped improve it. Now, has it improved health outcomes overnight? No, but it has been a case where we've been doing this a decade. It is a case where we've got a lot of cultural issues. How do we turn that around? But I think it is a model that I'm proud of, both under Governor Jindal and Governor Edwards, the privatization and expansion that has us going in the right directions. Secretary Greenstein has a lot of ideas about improving quality. In fact, we got a quality forum tomorrow that I have to go to. So it is a case where I think it is in the right direction, and expansion has allowed us to drive the federal money in order to do that.
But you think that's kept rural hospitals in Louisiana going compared to other states?
Yes, I do.
Before this?
Yes, I do.
Branching off of that, in your experience, is this the right way to go about Medicaid reform when we're cutting provider taxes and then kind of doing this cleanup on the back end? Is that the right way to go about it?
That's for the policy decisions and the politicians to decide.
You were a policy decider back then.
I was undersecretary at the point in time. It is a case where what I'm trying to do is identify the issues, educate everybody, and have our federal delegation understand, work with us. And during the debate on this bill, we were up there talking with, Speaker Johnson, Majority Leader Scalise, Kennedy, Cassidy, and they were all very receptive and helped us tweak the bill where they could in order to avoid that immediate impact that was being talked about if all of this went into effect immediately. What, the $4 billion I was talking about, we were talking about, it could happen this year in state fiscal year 26. So it is a case where, we are very thankful to those, the federal delegation working with us, listening to our concerns, and giving us time in order to address these issues in the out years. So that's how I would answer that.
That works.
We've got just 2 minutes left.
Yes, ma'am.
I have a question, just to clarify what you said. The 80-hour requirement only applies to those in Medicaid expansion, not to the legacy Medicaid folks.
That is correct.
Just wanted to make sure I heard you correctly.
Yeah, it only applies to the expansion population. It will only apply to a subset of that expansion population. Because you got to remember, in Medicaid Legacy, there's about 800,000 kids in that program, and there's 200,000 to 300,000 disabled and elderly in that program. So the nursing home clients are in that program. Anybody that's an adult that's been disabled is in that declared disabled is in that program, and then about 800,000 kids. So the work requirements does not affect them at all.
You mentioned the federal government and the federal delegation's support of some of your changes. Were there any suggestions, recommendations that you had that did not get approved?
really, we boiled down our ask to a couple, and both of those were addressed because we knew if we went in with a list of 20 things, it would, so we really focused on fixing the short-term issue and pushing it down the road a little bit. And some of that, why I was comfortable with that approach, you've got to remember that when the Affordable Care Act was passed, the federal government put in cuts to the uncompensated care pool that they were, as more people had insurance, there would be less uninsured, so they're going to ratchet that down. In Louisiana, that pool is about $1.2 billion a year. They have yet to implement that reduction in that pool because they keep pushing it down the road. Every time it gets sort of close, they push it down the road. I'm not saying that that's what's going to happen this time, but historically, that's, I've experienced that. So that's why I was comfortable looking for a short-term fix, and then we'll see what we got to do in the future to fix it going forward.
All right, well, that's about all the time we have today. Thank you so much. If we could give Jeff another round of applause.
Hey. I've loved it for a long time since I've been